Hello everyone, welcome back to Tutor Series. My name is Shujauddin and in today's lecture we're going to talk about RPGN, that is Rapidly Progressive Glomerulonephritis, and it comes under the heading of Nephritic Syndrome. So it's basically a type of nephritic syndrome. So what happens in RPGN basically is that you have a rapidly progressive disease that leads to rapid deterioration of your kidney functions, right? You have rapid deterioration of your kidney functions, and if you have rapid deterioration, so that means the patient is going to be symptomatic. Now the symptoms would be oliguria, anuria. The patient might not just be passing urine. So we're going to talk about the clinical features, but just to highlight what happens in RPGN is that you have a rapidly deteriorating kidney, rapid deteriorating kidney functions, and you also have crescent formation. So what is crescent formation? So basically, if you look at the glomerulus, so if you want to have an idea of what a glomerulus looks like, have a look at my video on nephrotic versus nephritic syndrome, where I've talked about what a normal glomerulus looks like. So you have two kinds of cells. You have visceral cells and you have parietal cells. Visceral cells are also known as podocytes, while parietal cells, they don't have another name. They're just outside in the periphery of your visceral cells. So in crescent formation, you have proliferation of your parietal cells. They increase in number, and with that you also have macrophages, monocytes, leukocytes, plasma cells. They all come and invade into the urinary space, leading to a formation of a crescent. Now crescent formation is usually promoted when you have leakage of your procoagulant factors, inflammatory markers, fibrin, and one of those procoagulant markers are also thrombin. So they all lead to a increased formation of your crescent, right? So you have crescent formation and rapid deterioration of the kidney in RPGN, and it is a type of nephritic syndrome. Now you have three different types coming under the heading of RPGN, and you have these three different classifications based on the immunofluorescence pattern that you see in each and every type. So let's talk about the first type, that what happens in type 1 RPGN. So what happens is that in type 1 disease, you have autoantibodies against your glomerular basement membrane, against GBM, right? Now if you have autoantibodies against your GBM, so you will have IgG immunoglobulins come up, and even the C3 complement components are also present. They also come and line your kidney, right? Basically your basement membrane, because you have autoantibodies. They're going to come onto the basement membrane and they're going to attack and destroy the basement membrane. So you have autoantibodies against your glomerular basement membrane. But if you were also having the involvement of your lung parenchyma, you have autoantibodies against your GBM, so that is type 1. But let's say along with autoantibodies against your GBM, you also have autoantibodies against your lung parenchyma. In that case, you call it Goodpasture syndrome. So Goodpasture syndrome is basically autoantibodies against both your glomerular basement membrane as well as your lung parenchyma. So be it just the autoantibodies because of any idiopathic reason, or due to a autoimmune disease, Goodpasture syndrome, which is, by the way, a type 2 hypersensitivity, because you have autoantibodies present. So in either case, you have type 1 RPGN. Now the reason, what component is the autoantibody targeting? Now be it just the basement membrane or both the lung parenchyma or the basement membrane, they both have one thing in common. What is that one thing in common? They basically have collagen type 4 in them. So you have autoantibodies against the non-collagenous alpha 3 chain of your collagen type 4. So autoantibodies against your alpha 3 chain of collagen type 4, right? This is against the this is what the autoantibodies are against. If they're just in the kidney, then it's basically a disease involving the basement membrane and that's it. But if it's both in the lung parenchyma and the kidney, then it's basically Goodpasture syndrome. And what is the autoantibody targeting? It's targeting your alpha 3 chain. Now, if it were Goodpasture syndrome, the person would come to you with hematuria as well as hemoptysis, like they would have symptoms in their respiratory system as well, right? So this is how you can differentiate. Now what happens is that since you have a basement membrane, like I said, to understand the complete glomerulus, do check out my video on nephrotic versus nephritic syndrome where I've explained that. So in a normal glomerulus, you have GBM, that is your basement membrane completely lining your glomerulus, right? So if you have autoantibodies depositing on your GBM, they're going to give you a specific pattern, like the antibodies are going to line against the GBM in a linear pattern. So you will see a linear deposition of your IgG on the basement membrane of a person having type 1 RPGN. So it's going to be linear in pattern because complete basement membrane gets affected by the autoantibodies. So you will have a linear arrangement. Now coming on to the type 2 RPGN. Now what happens in type 2 RPGN is that it's not idiopathic and it's not primary. It's basically due to any secondary condition that is involving the kidney. So it could either be due to lupus nephritis. A person had SLE and they develop nephritis. Now due to SLE nephritis, they end up developing crescents, right? They have antibody deposition. So due to SLE, all of this is happening, so they're going to come under type 2. So type 2 usually comprises of all your secondary causes that can lead to crescent formation due to systemic antibodies getting deposited inside the glomerulus. Over here you had no systemic antibodies depositing in the glomerulus. You had antibodies specifically targeting your glomerulus basement membrane. But in type 2, what happens is that you have a secondary condition where you have systemic antibodies that end up getting deposited in the glomerulus, and you end up having type 2 RPGN, which is a nephritic syndrome. So a few examples of type 2 RPGN include lupus nephritis. Apart from that, IgA nephropathy. In IgA nephropathy, you have IgA deposition in the glomerulus. Apart from that, you can also have a complicated streptococcal glomerulonephritis. Now what happens in streptococcal glomerulonephritis is that you basically have a infection that affects your kidney, but it's self-resolving. But instead of self-resolving itself, if it gets worse, if it gets complicated, you can end up having crescent formation. Apart from IgA nephropathy and lupus nephritis, patients who have Hinox-Schönlein purpura, they can also have type 2 RPGN. So HS purpura. So like I said, you will have a secondary cause with systemic antibodies depositing in the glomerulus, causing type 2. Now over here I mentioned that in type 1 you had a linear IgG deposition because obviously autoantibodies against your whole basement membrane, right? If this were your basement membrane, you will have IgG antibodies deposited linearly, right? This is how you would have deposition of your antibodies. So on immunofluorescence, what would you see? Linear deposition of your antibodies. So this is how you would probably see in immunofluorescence. Line se. Now what would happen in type 2 RPGN is that you will have granular deposition. It's going to be granular Ig deposits. Yeah, granular. Now if this were your basement membrane, right? It has 2 layers. So how would you see the deposition? It would probably be granular in nature, like this. It won't be linear. Do you think this is linear? No, this isn't. This isn't linear, it's granular in nature. You will have multiple IgGs in one place, and that's it. Yeah, just like this. So this is how you will have the presentation of type 2. Now coming on to type 3. Now what is type 3 RPGN called? Let me write the name down and we'll then discuss this type further. So it's basically called pauci-immune RPGN. Now pauci means low in number, reduced in number, or absent. So absent immune or reduced immune RPGN. What do I mean by reduced immune or pauci-immune? I mean that you don't have antibodies over here. In type 3, you have no immune deposition happening inside your glomerulus. You don't have IgG granular deposits or linear deposits, no. In type 3, you just have no deposits as all. But what do you have in pauci-immune? You have 2 things. You either have P ANCA present, or you either have C ANCA. Now try remembering a bit of your CVS module. In CVS you read vasculitis, right? Inflammation of your vascular wall. Now in vasculitis there were multiple diseases involving large arteries, medium arteries, small arteries, right? So P ANCA and C ANCA was being involved in a few vasculitis such as Churg-Strauss, microscopic polyangiitis, Wegener granulomatosis, right? So in Wegener granulomatosis you had C ANCA, while in Churg-Strauss and microscopic polyangiitis you had P ANCA mediating the whole damage. So keeping this in mind, what happens is that in type 3 you have no immune globulins present. Instead you have P ANCA or C ANCA circulating inside your blood. Now type 3 is either idiopathic in nature, or it could be secondary to Wegener granulomatosis, microscopic polyangiitis, basically secondary to vasculitis. So I'm going to write this down here, that it will either be idiopathic in nature, like idiopathically you will have increased numbers of P ANCA or C ANCA and you will see crescent formation in RPGN, or it would due to be due to a secondary vasculitis. Secondary vasculitis. So in either case, what is going to happen is that you will have P ANCA or C ANCA circulating in the person's body. So a patient is going to come to you with crescent formation. On immunofluorescence, what would you see? You will see no immune deposits. But in the blood, what would you see? Raised levels of either P ANCA or raised levels of either C ANCA. Now they could either be idiopathic in nature, like due to no other cause, just high levels of P ANCA or C ANCA, or they could due to be secondary vasculitis. And over here you will have your vessel symptoms as well, like in Wegener granulomatosis you have upper respiratory infections, you have lower respiratory infections in Wegener granulomatosis, urinary symptoms as well. In microscopic polyangiitis you have lung involvement and multiple organs are involved as well. In Churg-Strauss you have asthma, high levels of IgE levels present in a person's body. So you can easily rule it out on clinical examination whether it's idiopathic or it is due to secondary vasculitis. But coming to the point, you have high levels of circulating P ANCA or C ANCA, no antibodies, so no deposits seen. On immunofluorescence you won't see any antibodies, you would just see high levels of P ANCA, C ANCA circulating in the person's blood when you order their lab test. So no such thing on immunofluorescence. So over here I'm gonna write no deposits. So if you notice these 3 different types, you're gonna see a difference. In type 1 you had linear IgG, it was autoantibodies against your glomerular basement membrane, which is you had type 1. Over here you also had Goodpasture syndrome, right? Now the reason how these autoantibodies develop all of a sudden against your non-collagenous alpha 3 chain of the type 4 collagen, that is not known yet, but this is what happens in type 1. Type 2 is completely different from type 1 as well as type 3. You have granular deposits, and it is due to secondary conditions where you have systemic antibodies depositing in the glomerulus. In type 3, what happens is that you have no antibodies. It's completely different from these two types. In fact, you have P ANCA or C ANCA. It's either idiopathic or due to secondary vasculitis, and no immunofluorescence seen here. Now, if you were to look at a kidney morphologically of a patient that has RPGN, what would you see? RPGN has a pathognomonic morphology that is very specific to just RPGN. That is, you have segmental necrosis here, where you have adjacent glomerulus that is completely fine, unaffected, not inflamed, and then all of a sudden in between the normal glomerulus, what will you see? Segmental necrosis. So segmental necrosis is specific to RPGN, be it type 1, type 2 or type 3. So I'm just gonna write down here segmental necrosis. Right, so segmental necrosis is very much specific to RPGN only, and this is a specific morphology that you would see in a kidney of RPGN. Apart from that, you will see crescent formation. In crescent formation, like I said, it is either due to leakage of thrombin, inflammatory markers, procoagulant factors, or fibrin. So it's because of that. So you will have crescent formation, in which you will see parietal cell proliferation, thickening of your parietal cells, along with neutrophils, lymphocytes, plasma cells, macrophages, monocytes. All of these inflammatory cells are going to be present in the crescent, and these crescents are visible on morphology. You will have segmental necrosis, and in the glomerulus you will see fibrin bands deposited as well. And like I said, leakage of fibrin is responsible for crescent, right? So remember, fibrin bands will also be visualized in RPGN kidney, fibrin bands. So this is what you would see in the morphology of a patient with RPGN. So this is how their kidney is going to look like. That is something that is really important for you to understand. With IgG involvement, and like I said, linear involvement in type 1, granular involvement in type 2, and no kind of involvement in type 3. Now coming on to the clinical features. Now, clinical features are very easy to understand if you think about what kind of disease is this. Now, does this disease come under nephrotic or nephritic syndrome? I said it comes under the heading of nephritic syndrome. So it's going to have all those symptoms of nephritic syndrome, right? So what happens in nephritic syndrome? You have oliguria, you have reduced urine output. So that is going to be your first thing. Secondly, you have hematuria in nephritic syndrome. You don't have that in nephrotic. Apart from that, you will see RBC casts present in the urine of a patient with nephritic syndrome. Apart from RBC casts, you will also see mild proteinuria. And due to mild proteinuria, you will see periorbital edema, puffiness in the face, edema in the face. That's it. Due to mild proteinuria, you will have mild edema, and that mild edema would be on the face, periorbital edema, in the form of periorbital edema. So these are a few clinical features that you would see in a patient of RPGN. Now, how would you treat a patient of RPGN? We're gonna briefly talk about it, not gonna go in too much detail. So let's say you have type 1 RPGN. So what's going to happen is that it is a autoimmune disease, right? And you have auto antibodies present. So the first thing that you can do is you are going to do a plasmapheresis. Now, what is plasmapheresis? You basically recycle the patient's plasma, in which what do? You take out the auto antibodies, you take them out of the plasma, recycle the plasma with no auto antibodies and put it back inside the patient, right? So the first thing that you can do is plasmapheresis, especially for Goodpasture syndrome, in which you have auto antibodies, right? When you have auto antibodies, plasmapheresis is going to remove those auto antibodies, and that is something that you can do over here. Apart from that, what can you do? You can give the patient steroids, immunosuppressants to treat the patient's symptoms and disease. So give them steroids or immunosuppressants, right? Now coming on to type 2, over here you have secondary causes. So you need to treat each one of these causes that are leading to type 2 RPGN, and you're good to go in that. In type 3, if it's due to vasculitis, so you need to treat that vasculitis. If it's so idiopathic in nature, what you can do is you can give the patient steroids, painkillers, to improve their symptoms. So this is something that you do when a patient comes to you with RPGN. Now, keeping one thing in mind, that in RPGN, the name suggests that it's rapidly progressive glomerulonephritis. So it's rapidly progressive, that means you have rapid decline in your kidney function, and the patient can go into renal failure because of that. So you need to treat the patient promptly, do plasmapheresis, give steroids, immunosuppressants. Basically what you need to do is you need to preserve the person's kidney function, so that they don't end up having renal failure, going into dialysis or renal transplant, right? So we briefly talked about what happens in RPGN. It's a bit difficult. There are a lot of things that aren't clear. They're really just hypotheses, just suggestions, and that's it. A lot of things are uncertain, but I hope that me listing all of these things down made you help understand this topic in a much better way, how crescents are formed and everything. So thank you so much for watching. If you have any questions, feel free to write them down in the comment section or reach out to us on our Facebook page. Thank you so much. Stay tuned.